Hello, everyone. We will start our presentation regarding a 62-year-old patient who developed a hypersensitivity reaction after repetitive exposure to bee venom. 62-year-old Mrs. Young was stung by a bee from a hive in her back garden. Harvesting the honey had left her with several stings during the course of the summer. Several minutes after the recent sting, she complained of an itching sensation in her hands, feet, and groin, accompanied by cramping abdominal pain. Shortly afterwards, she felt faint and acutely short of breath. Moments later, she collapsed and lost consciousness. Her husband, a doctor, noticed that her breathing was rapid and wheezy and that she had swollen eyelids and lips. She was pale and had patchy erythema across her neck and arms. On examination, her apex beat could be felt, but her radial pulse was weak. Her husband immediately administered 0.5 ml of epinephrine intramuscularly and 10 milligrams of chlorpheniramine intravenously with 100 milligrams of hydrocortisone. She regained consciousness and her respiratory rate dropped. By the following day, she had recovered completely. Results of investigations at this time are shown in the table. So as we can see in the table, all the analytes except for IgE fall within the normal range. This result will be explained later on. Continuation. Mrs. Young had no previous history of adverse reactions to bee venom, foods, or antibiotics. In addition, there was no history of asthma, allergic rhinitis, food allergy, or atopic dermatitis. A diagnosis of anaphylactic shock due to bee venom sensitivity was made based on the history and investigations, and a decision taken to commence desensitization therapy. Mrs. Young was made aware of the possible risks of the procedure and consented to it. She was injected subcutaneously with gradually increasing doses of bee venom, and the procedure being performed in hospital with access to resuscitation apparatus. No further allergic reactions occurred, and she was maintained on a dose of bee venom at 1 month intervals for the next 2 years. She was stung by a bee the following summer and had no adverse reaction. So, based on the case, our patient is diagnosed of anaphylaxis or anaphylactic reaction. So, what is anaphylaxis? Anaphylaxis is a severe, potentially life-threatening allergic reaction. It can occur within seconds or minutes of exposure to something you are allergic to, such as peanuts or bee stings. The classic form involves prior sensitization to an allergen with later re-exposure, producing symptoms via an immunologic mechanism. So just like in the case of our patient, Mrs. Young, she had prior exposure to bee stings, and the anaphylactic reaction occurred on the most recent exposure. So the distribution, no, the causation, of this condition. So the body or the etiology. So the body is in constant contact with foreign substances. It produces antibodies to defend itself from these substances. In most cases, the body does not react to the antibodies being released. However, in the case of anaphylaxis, the immune system overreacts in a way that causes a full body allergic reaction. The IgE mediated mechanism of mast cell degranulation has been implicated in the pathogenesis of anaphylaxis triggered by a variety of agents. These include antibiotics such as penicillins and cephalosporins, foods such as milk, nuts, shellfish, or seafood, foreign proteins such as insulin, bee venom, wasp venom, and latex, and pharmacological agents such as streptokinase and vaccines. So for the epidemiology or the distribution of this condition, the true incidence of anaphylaxis is unknown. Some clinicians reserve the term for the full-blown syndrome, whereas others use it to describe milder cases. The frequency of anaphylaxis is increasing, and this has been attributed to the increased number of potential allergens to which people are exposed to. In a study conducted by Howe et al. In 2021, about the predictors of serious outcomes among patients with anaphylaxis seen in the Philippine National Tertiary Hospital, the results showed that there was a 193% increase in the number of cases of anaphylaxis from 2015 to 2019 in the Philippines. Recurrence of anaphylaxis reactions occur in 26.5% to 54% of patients, and the organ involvement and triggers of anaphylaxis are related to different age groups. Respiratory presentations occur more commonly in children, while cardiovascular symptoms predominate in adults. The highest incidence of anaphylaxis occurs in 30 to 39 years old age group. Food-related anaphylaxis was most common in children aged 0 to 9 years old. Venom-related anaphylaxis, most common seen in those 20 to 39 years of age. And medication-related anaphylaxis was most common in 30 to 39 years of age.
Okay, so now we will talk about the case history of a 62-year-old woman, Mrs. Young, who has been stung by a bee during summer. So as stated there, she has never had asthma, hay fever, or eczema, nor does she have a history of food allergies. Furthermore, she doesn't have a prior history of an adverse reaction to food, antibiotics, or bee venom. So Mrs. Young started to feel itchy in her hands, feet, and groin a few minutes after the most recent stung, along with cramping abdominal pain. She also felt dizzy, had trouble breathing, and shortly after that, she lost consciousness. Moreover, her breathing was rapid and wheezy, had swollen lips and eyelids, pale appearance, and had patchy erythema on her arms and neck. And she also had a weak radial pulse. So, based on the signs and symptoms, we can say that Mrs. Young had a severe and a life-threatening allergic reaction. So, allergies happen when our immune system becomes hypersensitive and reacts to a certain substances known as allergens. The presented allergen here is the venom from bee stings. So when this happens, our immune system will produce antibodies or known as immunoglobulins. So this will be further more discussed by the next presenter.
So now we have here the laboratory findings. In this table, we have the investigation conducted on our case, which is Mrs. Young. We have here from the hemoglobin down to IgA, we can observe that all the results fall within the normal range, except for IgE. This is because IgE is an anti-venom immunoglobulin, thus explains the increased levels which is shown in the results. It also says here that bee venom was detected, which is in class 4, and a skin prick test was also conducted. Next slide, please. Moving on, we have the clinical impression. Patient is a 62-year-old female who exhibits signs and symptoms of anaphylactic reaction based on the patient's history of having been stung by bees. The patient, after repetitive exposure to bee venom, has developed a sensitization reaction to the venom. Thus, the patient experienced the signs and symptoms of anaphylactic shock. In simple terms, a patient will only undergo anaphylactic shock after being exposed to the same allergen multiple times.
So let's move on to the pathophysiology of the disease. So anaphylaxis is caused by a massive release of biochemical mediators from mast cell and basophils. So mast cell activation occurs mainly via antigen cross-linking of IgE bound to Fc epsilon or I receptors on cell membranes. So, however, other membrane receptors can activate mast cells as well as potentiate IgE activation. The multiple activation pathways allow for immunologic This refers to an IgE-mediated activation or non-immunologic activation. This pertains to drugs directly interacting with receptors. So some antigens may mediate effects via several mechanisms simultaneously, such as vaspid venom, NSAIDs, or OSPATEs. So like other allergic reactions, an anaphylactic reaction does not usually occur after the first exposure to an allergen, but may occur after a person is exposed to the allergen again. So when we look back to our case study, uh, Mrs. Young was exposed to the bee venom sting again and again. So that's why she had an allergic reaction, because she already had um, an exposure to the allergen, which is the bee sting venom. So in IgE-mediated anaphylaxis, an immunogen cross-links membrane-bound IgE in previously sensitized mast cells. So immunogens are typically large foreign proteins with multiple epitope binding sites. So these epitope binding sites can be proteins in insect venom and certain foods. In this case, it can be the bee sting venom. So the stinging insects belonging to the order Hymenoptera produce venoms that can cause anaphylaxis. The important insects from this order include vespids. These vespids can be the wasp, yellow jackets, and hornets. And these can be the stinging ants. And most importantly, these can be bees as well. And the bees, in our case, are the cause of the anaphylactic shock for Mrs. Young. So continuation. So once activated, mast cells and basophils release a cascade of mediators, which cause physiologic changes, activate other immunology pathways, and attract other immune cells. Preformed mediators are released immediately upon activation, including histamine, tryptase, heparin, and chymase. So it is important to note that histamine has long been considered the principal mediator of anaphylaxis, and concentrations of histamine correlate with symptom severity. So Mrs. Young is diagnosed with severe anaphylaxis. So we can conclude that the histamine concentration is very high in her case, because histamine concentrations correlate with the symptom severity. So histamine acts on receptors to cause vasodilation, increase permeability, bronchoconstriction, and increase mucus secretion. So H1 receptors mediate coronary artery vasoconstriction, tachycardia, vascular permeability, pruritus, bronchospasm, and rhinorrhea. So this is just a simple this is a diagram of how anaphylaxis is the process of anaphylaxis. So it starts with the allergen. So our allergen in this case happens to be the bee sting venom. So the allergen enters our body, and antigens identify the trigger, and then the antibodies bind with the antigen to form an antigen antibody reaction. And this causes the mast cells and basophils to release histamine and bradykinin and leukotrienes. So histamine, as I said before, is the principal mediator of anaphylactic shock. So histamine causes the itchiness and redness, which Mrs. Young experienced. And the histamine and bradykinin leukotrienes causes vasodilation. And vasodilation results to a variety of uh, things, variety of happenings in our body. So it mainly causes a capillary permeability, increased capillary permeability, and this increased capillary permeability causes cell fluid shifting, and this cell fluid shifting results to edema, and this edema results to swelling, and this swelling can manifest in the skin, in the eyes, and the lips, which Mrs. Young had a swollen, as you can remember, has a swollen eyelids and the lips. It can also inflame the blood vessels, which results to a lower oxygen, which can lower our oxygen, and then this decreased oxygen is the results to a loss of consciousness, which, as you can remember, Mrs. Young also lost her consciousness. It's because of this. So it can also, the edema can also cause laryngeal edema, which can also cause this. So the increased capillary permeability also increases blood flow, increases glomerular filtration, increases urine output, and this causes shock. So the vasodilation, back again. So also causes maldistribution of blood. It decreases our venous return, decreases our cardiac output, lowers our blood pressure or hypertension, which Mrs. Young experienced, and also lowers our tissue perfusion, which can also result to loss of consciousness. So let's move on to the mechanism involved in the anaphylaxis. So anaphylaxis, as I said earlier, is arise from the activation of mast cells and basophils through a mechanism generally understood to involve the cross-linking of IgE and aggregation of the high affinity receptor, which is the FC epsilon RI. So susceptible individuals exposed to a sensitizing antigen produce specific IgE antibodies, which bind to high affinity IgE receptors, which is again the FC epsilon RI, and it is found on mast cells and basophils. So the receptor binds with the FC portion of the antibody, leaving the Fab binding sites available to interact with the antigen. So on subsequent exposure, which Mrs. Young, the antigen is bound by the IgE receptor complexes, which causes the receptor-mediated activation of the cells with the release of preformed and de novo synthesized mediators. And these mediators release on a large scale are responsible for the clinical manifestations of anaphylaxis. So the clinical manifestation of anaphylaxis is the skin reactions, which Mrs. Young experienced. She had itching and redness. It also includes hives and pale skin as well, and the flushing, which also Mrs. Young experienced. It can also cause the clinical manifestation also include low blood pressure, which Mrs. Young also experienced. As you can remember, she also had the wheezing because it is caused by the constriction of the airways and the swollen tongue or throat and the trouble breathing. And she also had a weak and rapid pulse. And these clinical manifestations are usually the characteristic manifestations of anaphylactic shock. So let's move on.
So what are the clinical features and management of acute anaphylaxis? So when patient has anaphylaxis, there are several parts of the body where the signs and symptoms occur. We have the skin, or also known as cutaneous. We have the respiratory. We have the cardiovascular, and we also have the gastrointestinal. In the skin, there are symptoms and signs of erythema, pruritus of hands, feet, and abdomen. We also have the symptoms of urticaria and angioedema. In the respiratory, we have laryngeal edema that causes hoarseness, and that may progress to suffocation due to deprivation of an oxygen. We also have bronchoconstriction, which causes wheezing, and we also have rhinorrhea. In cardiovascular, the patient may experience hypotension, arrhythmias, tachycardia, and vascular collapse. And lastly, we also have the gastrointestinal. Signs and symptoms include cramping abdominal pain, nausea, vomiting, and diarrhea. Next, please. So how do we manage acute anaphylaxis? Since acute anaphylaxis is a severe and life-threatening allergic reaction, it should have an immediate treatment. So here, the patient is placed in a recovery position. Oxygen is given by mask, and 0.5 to 1 ml epinephrine is injected intramuscularly. This has the effect of rising the blood pressure, increasing bronchial smooth muscle, and preventing further mediator release. We also have intravenous antihistamines like 10 milligrams of chlorpheniramine that can be useful because histamine can cause vasodilation, cardiac arrhythmias, and bronchospasm. We also have a treatment such as corticosteroids which includes 100 milligrams of hydrocortisone, and this may help to reduce any late phase response.
Now we are down to the last part of discussion, which is how may sensitivity be detected and what can be done to desensitize patients. The first step is to obtain a thorough history of previous adverse reactions. The timing and nature of such reactions should be noted. Skin prick testing with insect venom is a fast and sensitive method of detecting anti-venom IgE. Like I said earlier regarding the laboratory findings. Radioallergoservant test can detect venom-specific IgE, but are positive in only 80% of those with significant reactions to venom skin prick tests. Immunotherapy is best reserved for those with life-threatening systemic reactions to insect venom. The patient is given increasing subcutaneous dosages and then a monthly maintenance dose of 100 milligrams. The clinical protection rate is in the order of 98% for both adults and children. So to sum it up, the test that can be done to detect sensitivity is skin prick test, which is also known as puncture or scratch test. This test checks for immediate allergic reactions to as many as 50 substances at once. It is usually done to detect allergy towards pollen, dust mites, or even food. It is usually done in the forearm in adults, which you can see in the upper right corner. There's a picture there. And also, another test that can detect sensitivity is the radioallergoservant test. And also, immunotherapy is to desensitize patients. But take note that it is only best reserved for those with life-threatening systemic reactions to insect venom.
Okay, so to summarize this case, our patient, Mrs. Young, has experienced a severe anaphylactic reaction. Should take note that histamine is the principal mediator of anaphylactic reaction. So, number one, anaphylaxis is an emergent life-threatening condition and quick provider response is imperative. Number two, symptoms of anaphylaxis may include but are not limited to difficulty in breathing, an abrupt fall in blood pressure, edema, hives, itching, and gastrointestinal cramping. And some patients also experience loss of consciousness, just like our patient. Number three, anaphylaxis is triggered by a variety of agents, which include antibiotics, foods, foreign proteins, and pharmacological agents. And lastly, the timely administration of epinephrine is essential to the effective treatment of anaphylaxis. And such administration is dependent on correctly diagnosing anaphylaxis. So that has been our case of severe anaphylaxis reaction. This has been your presenter for today. I am Charla Ann M. Sabanal.
And I am Jessa Marie Porio.
I am Trixy Marie Pimentel.
And I am Reyna Niña Rizal, and this has been our presentation for our case study. Thank you for watching.